Good evening, everyone, and thank you all for joining us this evening for the 67 chapter on IASO Academics Masterclass series. I now invite IASO President Dr. Sharad Desai, sir, to welcome us all. Over to you, sir.
So, good evening, everybody. Today we have one of the most common cancers of the body, hopefully esophageal cancer, probably next only to cervical cancer, breast cancer, and head and neck cancer. And it's one of the most common cancer, ubiquitous all over the country. Everybody likes and to discuss this, and it's a very interesting surgical procedure as well. For today's meeting, we have Dr. Virendra Tiwari from the Tata Memorial Center, Mumbai, and he will be having holding the examination of Dr. Aditi Diwan and Dr. Sharad Zadav. And for the expert talk, we have Dr. Sunil Kumar from the All India Institute from Delhi. So welcome everybody, and over to you back over to you, Ziba.
Thank you, sir. Few instructions for our participants today. The first 1 hour will be the mock exam. Moderator for the same is Dr. Virendra Tiwari. So we request the moderator to kindly ensure that both the candidates today, Dr. Aditi and Dr. Sharad, get equal opportunity to answer, and that whenever questions are addressed, they are addressed to them by name so that there's no confusion as who's supposed to answer. The other thing for both examiners is, because this is a mock exam, unlike an actual exam, if they give an incorrect answer or if they are unable to answer a given question, we request you to kindly give us the correct answer which was expected. That's in interest of them as well as for the other viewers who are online or seeing this later. To both Dr. Aditi and Dr. Sharad, if you don't know something, there's no harm in it. You just say that you don't know it, and the examiners can move on. It will save us time. Keep an open mind and try to catch on their hints. To our viewers online, thank you for joining, and please, you can put your queries and you can put your answers or inputs in the chat box, and whatever remains to be discussed after the mock exam and expert talk, we would take those questions in the final Q&A session. With that, I request Dr. Virendra Tiwari to share his screen and proceed with the mock exam. Thank you.
Hi, good evening, everyone. Thank you, Ziba and Srijan. Thank you, Dr. Sharad, for giving this opportunity. I'll go ahead with moderation of the topic given, but I would request Dr. Sunil, Dr. Rudracharya, and Dr. Sharad also to contribute and add to the questions as we move ahead. I'll share my screen and we'll start presentation. Is it visible?
Oh, yes, sir.
Yeah, thank you. So, as we have already been instructed by Srijan, we'll stick to clinical stuff and the management protocols of related to carcinoma esophagus. We will not go much into detail as far as evidence is concerned, because that will be covered by Dr. Sunil in his expert talk later on. So one case we'll discuss in detail, and then 1 or 2 cases in brief regarding different clinical scenarios. So this is the first case, a 54-year-old male presenting with dysphagia since 1 month for solid, associated with weight loss, smoker for 20 years with no significant comorbidity. He is in good general condition, ECOG status 1, effort tolerance is 4 floor. So we have 2 examinees here, Dr. Aditi and Sharad. I'll start with Dr. Aditi first. So looking at the history, what is your clinical suspicion towards which organ are you suspecting is involved?
So the patient has presented with complaint of dysphagia. So the organ pathologic may be in the esophagus. or maybe in the supraglottic larynx or the pharynx.
So if it is larynx and pharynx, will you expect any other symptoms also rather than dysphagia alone?
It
Begin
will
with.
be associated with odynophagia and
Yeah. So now suppose we are considering this as a case presentation for esophagus. What are the risk factor that you can pick from this history and investigation with this history, which which will hint towards that malignancy, or what are the risk factor associated with carcinoma esophagus as far as the given slide is concerned?
First is a male patient, sir. Incidence of esophagus is more in males than females. Then next, he's a smoker with 20 pack per year. Smoking is also a risk factor for both adenocarcinoma as well as squamous cell carcinoma. And also there is history of weight loss that indicates that it is a malignant etiology.
Yeah. So four important factor, that is, first is male, gender, age more than 50, and smoker. These three plus associated weight loss. This will hint towards, these are the risk factor associated with carcinoma esophagus. Now coming to Sharad. So there are two important histologies that we get in esophagus. One is squamous cell carcinoma and adenocarcinoma. Can you elaborate some histology specific risk factor in this disease?
So in adenocarcinoma, the most common risk factor is being the tobacco and alcohol also, but along with high risk factor is a GRD, then Barrett esophagus. Yes, sir.
So
And
GRD.
in squamous cell carcinoma, low socioeconomic status,
Yeah.
then tylosis, then Fanconi's anemia or Patterson-Kelly syndrome with iron deficiency anemia. There is a chronic H. pylori infection in squamous cell carcinoma.
Yeah. So
And low BMI also is the one of the risk factors.
gastroesophageal reflux disease and Barrett's. These are the risk factor for adeno-CA. Whereas what you told, smoking, alcohol, yeah, common for both. Socioeconomic and tylosis, these are more H. pylori, more for the squamous cell carcinoma. Coming to Aditi, now patient presented with dysphagia. Can you, how do you grade dysphagia and why is it important? What is the clinical significance of grading a patient as for dysphagia?
So for grading of dysphagia, most commonly we use the TAHITA grading. Grade 1 is normal, grade 2 is need for liquids with solid food, grade 3 is semi-solids, grade 4 is not tolerating semi-solids, only liquids. Grade 5 is able to swallow saliva and grade 6 is not able to swallow saliva. So based on the degree of dysphagia, we need to decide whether we need to get a enteral access before starting of the treatment.
Yeah. And higher the grade of dysphagia, another important thing is that, even the stage or the primary is going to be bulky and more advanced kind of. So what you said, grade 5 and grade 6 dysphagia will have a bulkier lesion to begin with. And obviously, they will need some sort of enteral feeding to start. Now, coming to clinical presentation, Sharad, on inquiry, what other things will you ask for if you are suspecting carcinoma esophagus, which will, give you a brief idea about the loco-regional extent of a disease?
So I would like to ask for any difficulty. Is there any history of cough after taking immediate cough after taking food? Any change in voice?
Yeah.
Is there any regurgitation or like vomiting after taking delayed vomiting or immediate vomiting after taking food, sir?
An examination?
On clinical examination, in case of general C. esophagus, generally patient will be low BMI with significant weight loss, and abdominal examinations, positive findings getting is less likely, but supraclavicular nodes can be palpable in some cases.
So on history, on inquiry, you'll ask for change in voice and any signs or symptoms suggestive of aspiration, which will give you idea about vocal cord issues are involved by either primary or with the nodal burden or tracheobronchial infiltration.
Also, it's to rule out distant meds like any breathing difficulty or any bony pain, chest pain,
symptom, backache,
or any
tension. Yes.
history of seizure episodes.
Yeah. In this case, those things were normal and there was no supraclavicular adenopathy also. Now, how will we proceed? What investigation will we ask, Aditi?
Sir, apart from routine investigations, I'll get a upper GI endoscopy, and if there is any growth seen, biopsy from that.
Okay, suppose now, Sharad, you have sent patient to your gastroenterologist. What important finding do you want to see on in endoscopy report? What important parameters?
Yes, sir. Other than biopsy, I would like to see where is the site of lesion, what is the distance from the incisor, and what is the total length of the disease, distance from the G junction, and any secondary, any synchronous lesion in the stomach or in esophagus, basically to map the disease, sir. And if the scope is negotiable or not. If not negotiable, we may need to think for feeding, like Riles to pass beyond the growth, or feeding jejunostomy kind of, sir.
Why do you want to go ahead with feeding jejunostomy now?
No, sir, if a scope is not possible, but
is there any other way?
Nasogastric or nasojejunostomy we can pass, sir.
Yeah, so endoscopist can put a guide wire and pass across Riles tube or nasogastric mostly. That will be
nasogastric
and better also, or nasojejunal tube if needed. So no point in jumping for a feeding jejunostomy at this stage till we have clearly got the stage of the disease. So as Sarath has already mentioned, we need to get an exact mapping. What is the cricopharynx? What is the starting point? Whether negotiable? What is the distal extent of lesion? G junction, and what is the status of stomach? Is there any skip lesion? And if available, or if there are any biopsy from the primary as well as from the skip lesion. So suppose you find one or two, Aditi, one or two skip lesions. A main primary is starting from 30 centimeter in this case, and it is non-negotiable. There is another skip lesion at 25 centimeter. What other things you'll ask your endoscopist to do at that point of time?
Sir, we will take biopsies from other skip lesions as well.
Yes.
We can perform a narrowband imaging to look for any early stage
areas of dysplasia or skip lesion to exactly target the biopsy. Now, in this case, may not be very pertinent, but Sharad, when will you ask for a US in such cases?
On endoscopy, if there is a dysplastic changes or any history of any Barrett esophagus or any superficial tumor only, sir, limited to mucosa, and so in that cases, I would like to do EUS, sir. Like T1 and T2 lesions are better delineated by the EUS only, and it has a good sensitivity and specificity for regional node detection also.
Yeah.
So only early esophageal cancer that has a role, sir.
Correct. So in early, so in advanced like T3, T4, it may not, change your management much. It has the better sensitivity provided the scope is negotiable compared to your CCT component. But obviously that is not going to change your management. But in early lesion like T1, T2, as you said, it can change management. If you can confirm that it is T1, T2, you may not opt for any sort of neoadjuvant treatment. And those lesions are either endoscopic or can be planned for upfront resection also. So in this case, lesion was at 30 centimeters, scope was not negotiable. They did a biopsy and that turned out to be moderately differentiated squamous cell carcinoma. Dr. Sunil, Dr. Rudra, if you want to add something or ask something at this point, or should we continue?
Aditi, one thing is that, like you said, or rather, Sharad, the endoscopic ultrasound. So does it, if it's available at suppose you have access to that, will you like to go for it routinely?
Routinely, it is not done at our center, sir. Only if we get a T1 or T2 lesion, to confirm it as a T1, T2 lesion, we go for a endoscopic ultrasound.
All right. Given the nodal sensitivity, particularly the value of ultrasound, what do you think? Should it be employed routinely or not? You are right. I'm just trying to corner you, but you have to defend.
The sensitivity of EUS with FNA is highest for detecting nodal metastasis, but still we are not doing it on a routine basis.
Okay,
So-
all right, please.
Yeah, as Dr. Sunil pointed out, sensitivity of EUS is better compared to CT. And especially if you have earlier lesion where you are planning for a upfront surgery or endoscopic management, there you have to be very sure that nodes are negative. So EUS has another, role of sampling those nodes. So now we have done endoscopy, we found, we have got the histology also. Sharad, what investigation, what imaging investigation will you ask for next? And during endoscopy, as this was non-negotiable, your endoscopist has put a nasogastric tube also.
Uh, I would like to do a CCT thorax, abdomen and pelvis, sir. So if there is a no resource constraint, then I would like to go for a whole body PET CT, sir.
So what is better?
Sir, whole body PET CT has a better, it is to rule out the distant metastasis and also for the to check the prognosis of the patient, sir, because baseline PET CT and after treatment also, if there is a 35% decrease in SUV max, so that has a good prognosis, sir. There is a better overall survival in DFS other than non-responder group of based on the PET CT, sir.
Yeah, so PET CCT is a better investigation for upfront staging for, because we have good enough evidence which says that PET CT can overstage the disease in around 20 to 25% of cases.
Yes.
So if it is available, that should be what asked for. And obviously response assessment is better if you have a baseline PET CCT.
20%, yeah, 20% change of the management on the
Yes.
basis of PET CT.
Yeah. So Aditi, there is a mediastinal window and there is a lung window here on this slide. If you want, I'll play it again, but I want you to read exactly in what you see on this window.
So there's a growth in the lower third of the esophagus. The OG junction appears free, and there are no significant nodes. The lung parenchyma looks clear, no metastasis.
Correct. Good. So important thing is to look into the local extent of the disease, relationship with the surrounding structure. Most importantly, your airway, your pleura, aorta, lung. Correct. And the nodal burden. And this is the fusion image. Again, the disease is same lower third with no significant mediastinal or abdominal adenopathy, and biopsy is squamous cell carcinoma. Important idea to see for a lung window is that you rule out your pulmonary metastasis, plus you also get idea about patients, rough idea about patients' lung functions. So if parenchyma is good and his effort tolerance is good, obviously you get an idea that he is, kind of okay for as far as pulmonary functions will be there in future if you ask for. So now another thing that you look on a PET CCT is to rule out any anomalous structure. Obviously, you rule out M0, but in loco-regionally, you will also see, especially what you see, accessory or replaced left hepatic coming from the left gastric, or sometimes there are accessory tributaries to superior pulmonary vein. So these are the important anomalies that you also look into scan. So that was the case, but suppose now this is another case. I'll come to Sharath. Now in this case, disease is middle third and bulky one. So other than PET CCT and endoscopy, what other staging workup will you ask for in this case? I'll play this video again. So the case that we were discussing about till now was a lower third, correct? This is a bulky middle third. Any other staging investigation you'll ask for?
So we'll
If
do a bronchoscopy.
if a disease is around the tracheal bifurcation or above it, sir, generally in case of upper or middle esophagus, so bronchoscopy route is advised, sir, to rule out the tracheobronchial invasion.
Yeah, so on CT they can report as a bulge or a abutment, but when you do bronchoscopy, sometimes the abutment that is reported on PET CT can be can look like a infiltration, like what we can see here. So for a upper third carcinoma or middle third carcinoma esophagus, which is abutting your trachea, carina, or the bronchi, we should always ask for a fiber optic bronchoscopy, because there is no distinct, there is nothing in between esophagus and the membranous wall of trachea. So even the bulge can be reported as an infiltration, or subtle infiltration can be reported as an abutment. So fiber optic bronchoscopy will give you a better idea about the involvement or whether the tracheobronchial tree is free. Now, Aditi, when you do fiber optic bronchoscopy, how will you do how will you elicit whether that is involved or free if there is no significant infiltration seen?
Membranous trachea will move freely if there is no.
Yeah, so it is done, awake, a little bit awake, and you will ask patient to cough. At that point of time, you can see posterior membranous wall moving. So if it is free, there will be a bulge or it will move a little bit. But if it is restricted, that mobility will be lost. Dr. Sunil, you want to add anything or?
No, just since they are examiners, I'll give you by experience what the older examiners are very fond of asking students. One question is that what is the current role of barium swallow? You should be prepared that what you are going to answer. And second question is that, like it was a question of having grade 3 or grade 4 dysphagia, would you have asked for a stenting in this patient or not? One by one, you can take up either one.
Currently, sir, the role of barium swallow is not much. And the second question is about stenting. If the disease is resectable on the primary scan, and if you are going for a definitive surgery later on, so it's better to not put the stent. Other than you can put the Riles tube, like nasogastric tube also.
Any particular reason why you are afraid of stent?
After putting stent and after giving sir chemo radiation, so due to the difficulty in surgery due to adhesions, that could lead to more morbidity, sir.
Okay, because then the surgery becomes very clumsy and
Difficult, sir, yeah.
sometimes because the stent has been incorporated, because almost there is no mobility of the esophagus, and that's the reason technical challenges are there. But you should be aware about these questions. They will ask you.
So now, Aditi, coming back to our original case, lower third squamous cell carcinoma disease starting from 30 centimeter. Endoscopist has put a Riles tube. Now, how will you proceed with management?
We will start prehabilitation of the patient. We can start incentive spirometry early in the treatment, and echocardiogram, PFT, and DLCO. And if the patient is fit, we can go for a neoadjuvant CTRT with the cross protocols.
So, Sharad, what are the important components of prehabilitation? And is there any evidence to support prehabilitation, or just we go ahead and start prehabilitation in every patient?
Yeah, there are prognostic factors, sir, like nutrition, then lung functions, the level of the albumin.
So when you discuss about optimization in a case of CA esophagus, prehabilitation has a very important role. And we have enough evidence which says that, post-operative morbidity, mortality can be reduced if patient is properly prehabilitated. Three important component of prehabilitation. One is nutrition. Another thing is physical tolerance, where, you teach inspiratory muscle exercises and aerobic exercises. And third component is psychological well-being. A patient who has been diagnosed with carcinoma esophagus, if there is a component of depression, there is a very high rate of dropout, or there is a poor compliance to adherence to the treatment. So these are three important aspects that you will look into when you start management of a carcinoma esophagus. And obviously, as Aditi has told, if you have a doubt, it is better to get a pulmonary function 2D echo basic fitness investigation done to see whether patient is fit to go ahead with the treatment planned. That is what you said, NACT or NACT-RT followed by your surgery. So, Sarath, what neoadjuvant thing you'll prefer in this case, lower third squamous cell carcinoma?
Sir, in this case, I would like to go for a cross protocol, sir. That is a neoadjuvant chemoradiation with paclitaxel and carboplatin with a weekly for 5 weeks, along with 41.4 gray of radiation concurrently for 5 weeks, sir. 23 fractions.
Yeah, so
followed by
5 days and last week 3 days, 23 fraction, 41.4.
Yes.
So, Aditi, give me, tell me in brief, we will not go into detail. Tell me name. So one thing is cross trial. Is there any other trial that has looked into neoadjuvant chemoradiation followed by surgery? Just tell me name. Any other randomized control trial that you are aware of? So there is another trial from China, Neotrek 5010, I think. They have again randomized similar way, neoadjuvant chemoradiation followed by surgery compared to upfront surgery. And again, almost the same result they have found, significantly improved survival. So now this patient we have subjected to neoadjuvant chemoradiation. Aditi, patient has completed chemoradiation, finished 2 to 3 days back, and now he has come to your OPD. Now, how will you go ahead with this patient?
I would like to do a PET-CT after 4 weeks of completion of the radiation.
Okay. And why PET? Why not only CCT?
Sir, based on PET, we can assess the response better. If there is decrease in the SUV more than 35%, it indicates good response, and such patients have better overall survival and disease-free survival.
Yeah, so CCT is also an acceptable answer, but if you have PET CCT can also be done because it will give you not only morphological but the metabolical response also. So a better idea about response assessment with PET CCT. So you said after 4 weeks you'll do PET CCT. Sarath, when will you plan for a surgery? So 4 weeks have already gone. Patient has come with PET CCT now.
Surgery can plan for, sir, after 4 to 6 weeks. We can plan for surgery, sir, after proper prehabilitation and nutritional assessment status and pre-anesthetic fitness.
And will you repeat functional workup, PFT, DLCO? They were already done and were within normal limits. So would you like to repeat, or those values are also good enough for you?
2D echo and PFT, I would like to repeat, sir.
So yeah, so by 4 weeks, you should get a scan done, and within 6 weeks, you should operate also. It is better to repeat functional workup because of radiation as well as paclitaxel that you have given. That can also cause some ILD or fibrosis kind of changes and reduced DLCO. So it is better to get a functional workup again. If you have not done, then you have to do. If you had done, then it is better to repeat before planning for a surgery. And Aditi, is there any role for a delayed surgery post NACT-RT, or what is the good time to go ahead and operate?
4 to 6 weeks is the optimal time, but now we have the SANO trial, which has showed that even postponed esophagectomy, if the patient has a complete clinical response, the esophagectomy can be postponed and the survival is equal.
So this patient is absolutely fit. Good general condition, good effort tolerance. He has tolerated NACT-RT also. So will you give that option to this guy? Suppose this is his PET CCT. Faint avidity, but very good response. What are the problems of Sano trial?
Sir, in Sano trial, sir, in a total 300 patient, they 200 patient patient was on active surveillance and 100 patient they did surgery. But in 50 in surveillance group, among the 50% of the patient, they got the recurrence. But and after salvage surgery, but 2-year DFS and OS are similar, but they have short term result only, sir. Only 2 years. So long term data we don't
Very
have.
stringent follow-up you'll need.
Yes, sir. Three
Three
monthly
monthly endoscopy, EUS, bite on bite biopsy, sampling of nodes, PET CCT. So it's a very strict protocol and adherence is very difficult. In trial, maybe somebody was sponsoring, but if you tell patient to, put so much of money for follow-up with, anxiety that there may be a disease, still with negative biopsy, it's very difficult to convince. So, applying Sano is a little bit difficult, especially in such subset of patient who is absolutely fit to go ahead with surgery. A patient who has tolerated somehow not very fit, in those cases you can discuss and give that option. But in this case, I'm not sure. Dr. Sunil, what is your take?
Absolutely agreed, because doing a trial like that is one thing, but if you start trying to replicate that in day-to-day practice, that is absolutely, it's not going to work. Every 3 months, first year, every 4 months, second year, every 6 months, third year, just count the number of endoscopies, number of bite on bite biopsy. So it's not a practical idea to go for that. More so, like Dr. Virendra rightly said, that you have in the back of mind, the patient is always carrying anxiety that when it's going to recur, because I have not been given optimal surgical treatment.
Yeah.
So this is not advisable for, at least in our setting, as well as most of the settings of day-to-day practice.
So post NACT-RT, you should operate patient within 7 weeks. At 4 week, 3 week, 4 week, you'll do a scan. Within 7 week, you operate. If you delay surgery more than that, 7 or 8 week, the survival is going to go down and your surgical difficulty will also increase because of post-RT fibrosis. So within 7 to 8 week is what you should aim for to operate. Now, Sarad, patient, you saw post-chemo RT response also. You did functional workup. I had shown report also. PFTs were okay. 2D echo was fine. Now, what surgery will you plan for in this guy?
So in this patient, sir, lower say esophagus squamous cell carcinoma, I will do thoraco-laparoscopic MAC Evans 3-hole transthoracic total esophagectomy with cervical esophageal anastomosis, sir, as a gastric conduit with a 2-field lymph node dissection.
Okay. So you will prefer minimally invasive approach.
Yes, sir.
So Aditi, what is advantage of MIS over open surgery?
So with MIS, the pulmonary complications are lesser when compared to open surgery. And the oncological predictors, the lymph node harvest and the rate of R0 resection are comparable with open surgery.
Yeah, so short-term outcomes are better with minimally invasive and oncological equivalence. So what are two important landmark trials that you know?
The time trial, sir, and the Miro trial.
Yeah,
Time trial had compared minimal VATS TTE with open TTE, and the Miro trial was a hybrid trial that compared open versus open thoracotomy and minimally invasive abdominal component.
correct. In both trials, there was significantly reduced pulmonary complication. In fact, time trial, they had to close early because of the significant difference in both group. Now, Sharath said 2-field lymphadenectomy. Aditi, what are other types of lymphadenectomy that you are aware of in carcinoma esophagus surgery?
2-field, then there is extended 2-field, where we remove the right paratracheal. Then there is total mediastinal lymphadenectomy, and then 3-field lymphadenectomy.
In 3-field, what all things you'll remove other than your extended 2-field?
In 3-field, we remove the supracarinal mediastinal nodes as well as the cervical lymph nodes, sir.
Yeah, so 101, 104 according to Japanese classification plus left recurrent laryngeal node. And what you already described in your extended 2-field. So extended 2-field plus left aortopulmonary window, left recurrent laryngeal, and bilateral 101, 104 in neck. That is your 3-field. But here what Sarath said, 2-field is good enough because there were no significant supracarinal adenopathy and patient had a lower third lesion, squamous cell carcinoma. Now you have done surgery, minimally invasive 2-field Mackion's esophagectomy. Aditi, why can't you do ILE, Iolis esophagectomy in this case? Or can you do?
Since it is a lower third esophagus, sir, we can do a Lewis as well.
Yeah, agree. But what is the problem of doing Iolis esophagectomy?
The leak rates are lesser with the intrathoracic anastomosis, but the leaks in the neck are managed better, sir, if there is a leak. So we can manage it better in the neck.
Minimally invasive Machion versus minimally invasive Iolis esophagectomy, what I think, the thoracic anastomosis is slightly challenging compared to your neck anastomosis. So if you are very comfortable in doing minimally invasive Machions, that should be preferred compared to, open Iolis esophagectomy. Disease was starting from 30 centimeter, you can properly get a 5 centimeter proximal margin and you can do proper 2-field lymphadenectomy in both approaches. Then it depends what you are more comfortable in doing minimally invasive. If you are comfortable in ILE, that is also acceptable. But if you are not comfortable, then Machions. So because you need to give advantage of minimally invasive to patient. Dr. Sunil, Dr. Rudra.
No, I think it's going on very well. Yeah, I agree completely.
Okay, so now you have operated, patient is in your ICU. Aditi, now how will you take care of post-operative nutritional requirement?
Sir, on day 1, we start intraoperatively, we put a nasojejunal tube for all of our patients. And on post-operative day 1, we start clear water through the RISE tube 20 ml per hour and gradually increase to, by day 3, we start full nasojejunal feeds.
Okay, then when will you shift to orals?
We usually do a CT gastrographic on day 7 and then start on orals. And before that, we also do we look at the vocal cord status before starting orals for the patient. And if required, we do a functional evaluation of swallowing before starting.
Okay, Sharad, how will you go ahead? Same almost?
No, sir. As an institution protocol, we follow clear liquid we give orally at around day 4, day 4 to 5. Around day 4 only, before clear liquid, so we do FESR, functional endoscopic swallowing study. If there is no risk of aspiration of tolerating patient liquid, then we'll start on the liquid oral diet, followed by semi-solid and soft diet, sir. And on day 1, from the day 1 only, we start the FG feed, sir. On the first day, we start at 20 ml per hour, followed by 50 ml, then 100 ml gradually, then full FG feed from the day 4, sir.
Yeah, rate of feed depends upon patient's weight, patient's BMI also.
Yes, sir.
But usually from post-operative day 1, enteral feed is started. By day 3, day 4, you do Hopkins examination or what he said, FEES assessment to see if there is no vocal cord issues or there is no risk of aspiration. We start with water and then slowly, gradually increase. By day 7 or 8, patient goes on a solid diet.
Solid diet, sir.
Now, important aspect is that you should also look for a post-operative physiotherapy and mobilization. That is going to reduce your pulmonary complication. So physiotherapy is very important. What prehabilitation you had started pre-operatively should continue immediately post-operative also. Now, Aditi, patient has been discharged on day 8 or 9, comes to your OPD with the pathology report, and it is complete pathological response. T0, YP, T0, N0. Now what will you do?
I'll keep the patient on follow-up, sir, since it is a pathological complete response.
Okay. Now, Sharad, suppose there is YP T0, N1.
Sir, as per evidence, there is a checkmate trial, sir, checkmate 577, that suggests a patient with R0 resection, and if there is a residual disease, there is a 50% disease-free survival benefit of around 11 months if you give the nivolumab in the adjuvant setting, sir.
How long?
Exact, I don't know, sir, like 1 year.
Yes.
I'm not sure, sir.
Yeah.
1
So
year.
checkmate 577 that says that if there is a residual disease post any CTRT, you can continue or you can think of, but only DFS benefit.
Yes, sir.
Okay. Now we'll stick to same clinical and radiological features, but suppose to begin with same lower third disease, endoscopy disease starting from 30 centimeter, non-negotiable, but biopsy was adenocarcinoma. Now, Sharad, how will you go ahead with this guy?
So if we have given a cross protocol, sir.
And what neoadjuvant protocol will you prefer? Will you prefer cross or will you try to change?
Yeah, sir. There are options like recently there is Esophageal trial, sir, that compared with the cross protocol and float regimen, sir. So in the float regimen, there is a 7% of
detail we don't need.
yeah.
So neoadjuvant protocol may change.
Perioperative float therapy also we can use, sir, in adenocarcinoma, distal esophagus and G-junction.
Now operated, Aditi, same adenocarcinoma, guy has come with T0, N0. Now what will be your adjuvant protocol? You had given float.
So we'll complete the perioperative chemotherapy. 4 more cycles of float will give.
Yeah. So adenocarcinoma, it is float, whereas in squamous cell carcinoma, it is cross followed by follow-up, or if there is residual disease, you can think of this adjuvant. Now, what are the important post-operative concern in a case of Mackion's esophagectomy? Aditi, immediate post-operative.
Immediate post-operative complications may include pulmonary complications, lung atelectasis, pneumonia, then cardiac complication. Most commonly, we see arrhythmias, atrial fibrillation. There can be mediastinitis. There can be anastomotic leak, and vocal cord palsy can be there.
Correct. And Kyle.
Kyle leak, yes.
Yeah. So 4 important thing that you are scared of is your pulmonary complication, anastomotic Kyle, and what you said, hoarseness or aspiration. So Sharad, will go to these complication one by one. How will you try to prevent? It is, always better to prevent rather than manage those complications. So pulmonary complication, what precautions will you take to prevent post-operative or reduce post-operative pulmonary complications?
To reduce the pulmonary complications, sir, the preoperative rehabilitation is very important in that, like spirable exercise and protein diet for adequate muscle bulk of the chest also. And second, intraoperatively, sir, to check the vascularity of the conduit.
Pulmonary complication.
Yeah, pulmonary. Yeah.
So exercise, prehabilitation. So inspiratory muscle exercises like spirometry or simple coughing can also, prevent these issues in post-operative period. Now, Aditi, anastomotic leak, how will you try to avoid or prevent?
The vascularity of the conduit, we can check intraoperatively using ICG. Next thing, we do a stapled anastomosis at our center using linear staplers. So stapled anastomosis has lower leak rates than the hand sewn.
So 2 important thing is that vascularity and the reach. It should be tension-free anastomosis. Correct. And there should be good vascularity. When you are mobilizing esophagus, at that time, there should be minimum handling to conduit, because that is what you are going to pull into neck and do the anastomosis. So reach should be tension free and good vascularity. Try to preserve right gastric artery also if possible. Good mobilization, cauterization. And if suppose it is not reaching, then in those cases, you can take right gastric. but right gastroepiploic and right gastric you need to save. And suppose you are having a problem in the conduit reaching to neck, what all measures can you take to improve the reach into neck?
Duodenal cochleation can be done, sir.
Yes.
And releasing adhesion in the region of gallbladder there and around the right gastroepiploic region, sir. Distal stomach can be mobilized, sir.
An important thing is how you make your conduit. If you follow greater curvature, you will get another 1 to 1.5 centimeter extra length. You can end your conduit formation closer to pylorus to get a little bit extra length. And if needed, you can sacrifice right gastric, but keep those options as late measures. So now coming to chylothorax, how will you try to prevent, Aditi?
Sir, intraoperatively, identification of the thoracic duct. We don't ligate it routinely, but if there is any injury to the thoracic duct, we ligate it. And we can also use ICG for identification of the thoracic duct. We inject ICG in the inguinal region at the inguinal nodes, and then we can
Correct.
be.
So ICG is one way where you can identify the exact location and whether you have injured thoracic duct or not. If you have injured, you have to clip. Sharad, suppose you have injured thoracic duct somewhere close to when it is going from right to left side. So where exactly will you clip thoracic duct, and what is the landmark to identify? ICG you have used, so that is one adjunct, but where exactly, what point will you clip thoracic duct if you have to?
Infraazygous in the infraazygous region, sir. Between the descending thoracic aorta and the azygous vein, sir.
So ideal,
In that region.
ideal, but usually we try to clip at the site of IPU or slightly below IPV, because there may be multiple channels if you go below that, and that is the point where it confluences and becomes one more in 50% of cases. And if you go too below that, then also you may not completely completely get the thoracic duct. So ideal usual site is to clip close to IPU or slightly below IPV, inferior pulmonary vein level. Now next complication that we thought of is a recurrent laryngeal nerve injury. Aditi, how will you prevent, how will you try to avoid that complication?
So during the mobilization of the upper thoracic esophagus, and during the mobilization of esophagus in the neck, we need to identify the recurrent laryngeal nerve and preserve it.
So 2, 3 important points that we say when we mobilize esophagus is that try to mobilize as much as much you can go up into thoracic inlet or slightly into neck area from thorax itself. When you go up from thorax, you will obviously isolate recurrent laryngeal nerve and it will be pushed towards your airway. So you will not have to dissect much from the neck. That is one thing. Second thing is that when you are starting your neck part, make sure that there is no rigorous retraction on the medial side, that is towards trachea side with metal or your retractor. So these 2, 3 are important point how you can avoid injury to recurrent laryngeal nerve. Dr. Sunil, anything?
I think we got a message that it's better if we answer some Q&A in the chat box in the live form. So should I read one by one?
Yes, please.
So the first question said, I think that was adequately answered. What about the role of barium swallow, like I asked? Currently, essentially, there is not much of role. But then if you ask about certain role for gastrography study in pre-op or in any other situation, one, it could be that in the palliative setting, you want to know the track of the growth or the opening. So there, before you put your scope and try to dilate that, before dilatation, it's always better to get the idea about the track, and that's where the dye study helps you. Apart from the routine practice of post-operative evaluation, I'm talking about non-operative scenario. Barium swallow, not much of role. Next question is that maybe Dr. Virendra would like to take up. What is the protocol followed after an Ivor-Lewis esophagectomy? Is it same as cervical anastomosis or different?
We follow exactly same as cervical anastomosis. Only thing is that in IOLOS, you cannot put nasojejunal tube on table. So it is IR guided nasojejunal tube on post-operative day 1. And then feed is started. We don't do FJ. Feed is started on day 1, nasojejunal. And exactly same way on day 4, there is no need for Hopkins because you have not gone close to recurrent laryngeal nerve in IOLOS esophagectomy. Day 4, we start patient on water. Day 5, we slowly increase if everything is uneventful. Day 6, he goes to liquid diet. By day 7, goes to soft diet. And then once he goes to liquid diet or soft diet, we reduce nasojejunal feed to 50%. Exactly same as a Makion's esophagectomy.
Next question, can we give float if it is not a G junction, that is only a lower thoracic esophageal adenocarcinoma? I guess all the trials, they have included lower thoracic adenocarcinomas, and float is being utilized equally well for all these tumors as well. So protocol is same whether it is G junction or lower esophagus. Next question, how do we manage conduit leak, sir? Dr. Virendra.
So that is what I have. So we'll go ahead, we'll discuss this with our examinees also. So Aditi, suppose on day 4 you have operated, patient on morning round, you see fever and tachycardia. What all investigations and how will you clinically assess that guy? On post-operative day 4, when you see early in the morning, patient has got 102 degree Fahrenheit and pulse rate is 120.
Sir, we'll do routine hemogram procalcitonin, and we'll look at the neck drain output, and we can get a imaging to rule out anastomotic leak, sir.
So first and foremost important thing is to get a clinical assessment. What is the vitals of patient BP, blood pressure. Second thing is you need to examine wounds. What is the status of neck? If you have put a drain, you need to see what is the nature. If there is no drain put on the neck region, we usually don't. So in that case, you need to examine whether there is any redness, any signs of inflammation or swelling over the neck wound area and other wounds also, and get a chest X-ray. If there is a inflammation or issues at the neck area, you need to open suture and drain things and give wash in that area. And your chest X-ray is okay, patient is vitally stable, and counts are also fine. Then there is no immediate need to push for a scan. But if patient is, vitally not that stable, or if your chest X-ray has shown some air fluid level, in such cases you need to get a scan done. Sarath, what is the important advantage of doing CCT in such cases?
If there is a leak, sir, if there is a leak in the mediastinum, that may can happen, sir. Seepage of the anastomotic leak content that could cause a mediastinitis, sir. So collection or any if we view, or generally we don't prefer oral contrast, but collection we can see oral contrast given, we can see the leakage of the contrast into the thoracic cavity, sir.
So important idea of doing CCT is not to diagnose leak, but to drain the leak. So if you have got some collection into thorax or mediastinum, the important idea is to drain. And most of these leaks are managed conservatively. So if there is a neck issues, you open neck, give wash. If there is a thoracic collection, you try to drain and start antibiotic according to culture, and follow up how the patient is behaving. Keep nil per oral and see if patient is improving. I think then your conservative management is working. But if there is any clinical deterioration, patient is still having fever, then in such cases you may ask for a endoscopy also to see status of your anastomosis and the conduit. Dr. Sunil, am I answering what was asked, or do we need to?
Yeah, this was precisely the one more thing. If you can clarify that, what is the role of endoscopy in a neck leak situation?
So what I said, first thing is to go ahead with conservative. You do not have to push for endoscopy in all cases. But suppose you did a CCT and there is a significant contrast extravasation into thorax, or if your conservative management is not working, patient is not becoming better or throwing fever on and off. In such cases, or if there is a very significant clinical deterioration, like your ABG, there is a high lactate, patient's blood pressure is falling, significant tachycardia, patient is leading NORAD. In such cases, you are expecting a significant dehiscence or you are expecting a conduit issues. In these cases, you need to ask for endoscopy. If there is a anastomotic dehiscence only. So what we have started, suppose there is a less than 30% or 1 centimeter, 1.5 centimeter of dehiscence, then your conservative can work. But suppose there is a significant anastomotic dehiscence, like around 2/3 or half of your anastomosis has given way, and the anastomotic dehiscence is leading into thoracic cavity. In such cases, we have used endosponge also. So not only to diagnose, but also to treat, your endoscopy is very helpful. You can plan for a endosponge. Sponge is placed into thoracic cavity, and that is connected through a Riles tube to a negative suction device. Every after 4th or 5th day, you repeat endoscopy and change endosponge. Slowly, what happens, that cavity closes off, and it will seal the dehiscence also. It takes time, but that is, in significantly poor situations where you have to go for disconnection and other ways. This has helped us a lot.
Great. That was really answered well, because that's a new armamentarium in the management of leak, and it has changed the situation remarkably. I think we can.
So now,
So if I can comment, Dr.
Yes, sir.
Rudra here.
Yes, sir.
So it will depend on type of anastomosis. Even we have seen minor leaks in the neck with saliva coming, but minor leaks can be managed with a stoma bag, and you can open 2 or 3 sutures, and sometimes it presents just as a abscess, and by 7 to 15 days or 3 weeks, by virtue of secondary healing, it heals. So that is very common. But definitely, if there was any vascularity jeopardized in the gastric conduit, although it is not very well proved, but we use ICG regularly to see the tip of the stomach tube till where in 60 seconds where it reaches the ICG, and we sacrifice the distal part, which can be very well get anastomosed to the esophagus. And then the chances, what we have noticed is from 4%, the chances of leak have come to 2%. So although the venous part is not answered with the ICG, it is only ICG takes care of the arterial thing. But still, what we feel is the way the greenish ICG appears, the same way it disappears also. So if your venous flow is good, and the disappearance will be fast. So that way you can make a mark out that where you want to sacrifice the terminal trip. And if you have a good habit of using it regularly, then you can use this method to have a less chance of leak, because what post-operative complications is best to prevent it. If you are not able to prevent, by chance you have it, then you should have all the 1, 2, 3, 4 what you will do in the post-operative period, so that 60 to 70% of these patients can be salvaged. So that is my intent. And if it is a intrathoracic, I think sometimes you have to see the CT with a mediastinal leak versus a leak which is happening to the pleural cavity. And according to that, the primary ICD never drains actually. It always stays inside the thorax. So according to that, either you put a mediastinal drain or a para conduit drain, so that it is properly drained. Even sometimes proper drainage with minor leaks, it gets very well sealed. So all these things are important. I think managing complications of esophagectomy is a big challenge, but prevention is the best thing.
Yes, sir.
Dr. Virendra, 10 minutes for the remaining
Yeah, done.
cases.
Last
We'll
2
go back
slides.
to the
Yes.
examinations. Yes.
Yes. So, Sarad, now this is a scan, and I'll show you fusion images also. Again, we are not going into detail of clinical fitness and other stuff. Suppose patient is fit for your treatment. Now, this mid-third disease, bulky squamous cell carcinoma, and this is the fusion image. What do you think about scan?
There is a large bulky left paratracheal node, sir, along with looks like resectable primary middle esophagus.
So now bulky middle third with the left tracheoesophageal groove node. Sorry. Now, Aditi, suppose you are planning for, obviously patient will need some sort of new adjuvant. What new adjuvant? Biopsy is squamous cell carcinoma, middle third bulky lesion with the left neck node.
Since there is a distant node that is away from the primary, systemic therapy, I'll prefer with a neoadjuvant chemotherapy, sir.
Why will you not plan for chemo RT?
Chemo RT, the field of the chemo RT will have to cover the primary as well as the node. It will be a
Yeah, so white field is
Probably
one
yes.
region, plus if they cover your neck node also, they will be irradiating cervical part of esophagus, which is, going to come for anastomosis later on. So obviously around 40 gray of radiation to neck you want to avoid. So yeah, neoadjuvant chemotherapy. Now, Sharad, what will be extent of nodal dissection in this guy?
In this case, sir, I would like to do three-field lymphodissection, sir. Because as per evidences, in upper and middle thoracic esophagus, there is a better staging with that, sir, with accepted complications.
And what post-operative concerns you have with three-field?
There is a high recurrent laryngeal nerve palsy in this case, sir, and pulmonary complications also more.
Yeah. Now, Aditi, now this is another case. Endoscopy lesion is starting from 19 centimeter. Biopsy is squamous cell carcinoma. You have done fiber optic bronchoscopy, that's normal. Now, what is your plan?
Since it is a upper thoracic esophagus, it will be difficult to get the proximal margins surgically. So preferred modality will be a definitive CT-RT for this patient.
Yeah, so these patients, these subset of diseases are not amenable for surgical management because of two issues, proximal margin as well as very closeness to membranous wall of trachea. So here, the idea will be to go ahead with definitive chemoradiation. Suppose, Sharad, after a year, this patient comes back to you with dysphagia, endoscopy we did, and there is a residual lesion at 20 centimeter, biopsy is positive. Now, what are you thinking of?
In operative case, sir, after
Post neoadjuvant, post definitive chemoradiation.
post definitive chemoradiation, sir, I will do the biopsy. If it is positive, I will go for a definitive surgery, sir. After
What
restaging.
surgery? Salvage esophagectomy you are thinking of. So how will you counsel patient? What are
Yes,
the
sir.
problems of operating a patient who has already received a definitive chemoradiation?
So in salvage esophagectomy, as per Sanotrial also, sir, there is a increase. There is a acceptable morbidity as compared to observation also, with a survival benefit also. So in this case, with accepted morbidity, we can go for salvage esophagectomy, sir. But in this case, if we're not getting margin, we may need to go for a laryngopharyngectomy also, sir.
In Sano, it is 41 gray. Here you have given 50.4.
50, sir.
Yeah. So Aditi, what is your opinion? What is your take? How will you discuss with patient?
Sir, in salvage esophagectomy, the rate of complications, post-operative complications are higher. There is high chance of anastomotic leak and increased chances of injury to the recurrent laryngeal nerve also.
So again, in salvage setting, no, suppose patient has come with residual disease surgery is going to be very, very morbid. Anastomotic leak ranges from somewhere 30 to 40% because patient's neck area on the esophagus that is going to come for anastomosis has been irradiated. So anastomotic leak rate that you have to explain them about. And what happens, when you have done surgery after chemo or neoadjuvant chemo radiation, the anastomotic dehiscence sometimes heals, or most of the time it heals on conservative management. But these kind of anastomotic leaks take significant amount of time to heal on its own, and they may need other interventions also. There is a significant pulmonary complication, and with leak, the mortality rate is also significantly high. Another issue is that the plane with trachea is very difficult. So if such subset of patient comes to you, then there is another option to downstage again with chemotherapy or chemo plus IO if patient is affordable, and then plan for surgery. But again, in spite of those things, the mortality is significantly high in salvage esophagectomy. I think that's it from my side. Dr. Sunil, Dr. Rudra, anything to add?
I think that was great. Remaining two questions are there, rather three questions. One is that how many sittings of endosponge can be used? I think you have already answered every 4 or 5 days.
5 days, yeah. Usually they will need 3 to 4 sitting of endosponge.
Yeah.
But after 4 or 5, it is not settling, then less likely to improve with that.
The next question is that which side recurrent laryngeal nerve is prone to injury in esophagectomy? I think one of the examinee can answer that.
Sir, in cases if you do the supra azygous dissection, the most common injury occurs is a right recurrent laryngeal nerve, sir. In cervical anastomosis, while doing dissection, left recurrent laryngeal is common to injure, sir.
Any particular reason for that?
In cervical anastomosis, if you use if you're not using the gentle retraction and using the cautery, that can cause the injury, sir. So sharp dissection is advisable with scissors, sir, fine scissor.
I think if there is only 2 filled nodal dissection, then your left recurrent laryngeal nerve is at risk. But in 3 filled also, you have to dissect left RLN for a long length from aortopulmonary window all the way till thoracic inlet. In such cases also, I think that is at the more risk compared to right. That's my opinion.
Yeah, in general, the left side is much more vulnerable.
Yeah, so that is why the question is very trickily asked. Which side recurrent laryngeal nerve? So the answer is left side actually.
That's a common question you'll be asked as well.
Right. I think we'll thank our moderator, Dr. Virendra, the examinees, Dr. Aditi and Dr. Sharath, for the excellent mock exam discussion that happened. We move on to the next phase of this webinar, which would be the expert talk delivered by Professor Sunil Kumar, who requests Sir to kindly share his screen. After his talk is done, remaining questions that are remaining we'll share with both the examiners. I request Dr. Virendra to hang back. Over to you, sir.
Thank you, Srijan. Over to Dr. Sunil.
Yeah.
We don't yet see it full screen, sir.
Yeah. Just try to share it again. No. Why the slides are not? My slides are not visible yet?
We see your complete PowerPoint screen, sir. We are not seeing it full screen yet. We are seeing
Okay.
Now.
Right.
Yeah, there you go, sir.
Okay. Thank you very much. After this very much interactive discussion, I think most of the things have been covered. What I am going to do is to essentially summarize and put them in perspective so that you have a concise picture. Obviously, 20 minutes is too little for covering the entire topic. And the best thing is to go for a pointed discussion that what all points we need to, particularly from the examining point of view, that certain contentious issues, certain controversies, and you should have a clear take. Like every time Dr. Virendra was asking that, what is your take on that? So there are certain points where there is no clear-cut answer, there is a gray area, but you should have your answer ready with the logic behind that, why you are trying to answer like that. So that's the whole idea. And greetings from All India Institute. Just to give you that if you try to, or if you make a choice to make a career out of esophagectomy, there is ample for you. And Globocon is the best evidence, not only in 2020, but if you extrapolate this to 2040, you can see that almost the number of cases which are going to be esophageal cancer overall are going to be doubled. Although they are 5% of the total cancer cases, but that's a huge number. And this was the world picture. But if we come to our own country, and this was our registry data, we were also part of that. So estimated cases in this article came in 2020. That was at that time expected to be more than 50,000, around 52,000 to be precise. And somewhere in last 5 years or 10 years, it has taken over CS stomach as well. You can see in the table. And now it has become the most common GI cancer in our country. This is going to grow only. So if you are going to be a esophagectomy surgeon exclusively, you are going to be really busy, believe me. But important thing is that the profile of the esophageal cancer itself in India is also changing because of the dietary pattern or number of other factors, which I am not going to detail into. But then, yes, now the squamous, although that is still predominant variety, but then lower third and adenocarcinoma, because majority of the lower third tumors are adenocarcinoma, they are picking up as well. And the ratio has become almost to the tune of 2/3, 1/3, or rather 60/40. But there has been evolution over time, and I will not be going much into detail of the workup and assessment or optimization, because that was the idea in the interactive case presentation, and that has been amply covered in details as well. But important is that we have to recognize that adenocarcinoma versus squamous cell carcinoma, the treatment strategies are changing. They are different. And that's the reason why it is important that when we talk about the changing paradigm, we have to remember certain factors as well as the recent evidence also, why they are changing. Then other point is neoadjuvant strategies, that is chemoradiation therapy versus chemotherapy. Every time we talk about cross protocol or any rather second Chinese trial, it's a kind of an unequal comparison. You have got 3 modality versus 1 modality. So many times the question comes that, was it an unfair comparison? What about 3 modality versus 2 modalities? That also we will be talking about. Post-neoadjuvant therapy, post-neoadjuvant chemotherapy, again, the question which was already discussed, and that was whether we should observe or surgery, that is now opening coming up. And there is an argument for that, but how strong argument is that, still not very convincing, or rather not much of evidence is there completely, so that we can shift to routine basis. And 3 points is surgery, briefly we'll cover. One is, and had been partly discussed also, that in a esophageal cancer, is there any place for thoracic anastomosis or Ivor-Lewis hysterectomy versus McKeown's, or should McKeown's be routine? Then the method of the surgery, that is MIS versus traditional method. And also within surgery, the extent of lymphadenectomy, which has an age-old debate, but then for your purpose, there has to be one take and you should be able to answer the questions in the exam. Little bit about role of immunotherapy. Workup part, I am not going to detail again. It has been like endoscopy with biopsy is the primary modality with the first diagnostic investigation. PET-CT, this is for both primary and mediastinal nodal, as well as obviously distant recurrence. But endoscopic ultrasound, when it's available, when you are making a choice, there are certain riders to that. One is that it is good and optimal only for possible tumors, not for stricturous tumors or not possible. Then the assessment is not complete and the findings are not very reliable. It's good for nodal evaluation, but then PET-CT is also giving you very, very important input about that. So if you have a routine policy for nodal addressing, this finding will matter only in a situation where there is a question of residual node or response to node or not. So that point is also very much not very critical. Important is that you should remember that endoscopic ultrasound, it overstages the T2 and understaging will be happening in T3 between these two groups. But our primary purpose was to differentiate anything from T1 to non-T1, because most of the trial and most of the centers now will be incorporating in the domain of neoadjuvant treatment, because that was the idea, whether to go for upfront surgery or neoadjuvant treatment. Why a good nutritional evaluation is must? Because you should understand the rider that most of the trial, including cross trial, they've excluded all the patients who had more than 10% weight loss. Although that is not a sacrosanct criteria for not offering neoadjuvant or cross protocol for these patients, but you should very much keep in mind because the toxicity and the attrition rate is going to be very high. So you should not plan for something which is going to be a detrimental for the. So neoadjuvant planning has to be in a very careful manner. It is based on not only just that diagnosis of squamous cell carcinoma or adenocarcinoma esophagus, but apart from that, what patient can tolerate and what patient can complete, because once everyone. So some sort of enteral nutrition route has to be placed, and that is important that nutritional rehabilitation starts right on day one. Majority of the patient will be nutritionally debilitated, pay a heavy price as far as the post-operative outcome is concerned. Also, the pulmonary function evaluation, basic clinical evaluations like how many floors patient can climb, 6 minutes walk test, etc. These are, and breath holding time. These are very much good enough. And PFT, if you combine that, that gives you a fair amount of idea. Yes, you may also go for DLCO or cardiopulmonary stress testing. It's important to start home spirometry exercise right in the beginning. Now, that was the first point of discussion, that what about adeno versus squamous? Should they be treated equally or there is a difference? Now we are getting that actually these two are totally different diseases. Still, by the previous literature, they have been clubbed in the domain of CA esophagus, but they are having a different etiology, different location, different biology altogether. Also, their outcome, the post outcome in terms of recurrence and the site of recurrence. Adenocarcinoma is more of a systemic disease where systemic component of the treatment predominates, and there is a questionable benefit of RT, which is coming now more and more apparent in the recent trials. So different strategies for neoadjuvant treatment has to be there for these, and trials for adenocarcinoma, particularly for lower esophagus and G junction, they are showing limited benefit of RT. Case in point are 3 trials. The first, it started with NeoASIS that came in 2023. And this was utilizing essentially comparison of perioperative chemo versus cross regimen. So it was seen that essentially there was not much of difference in the median OS, which were almost equal, also in 3-year OS and median DFS, either also in PCR rate or R0 resection rate. So no difference in recurrence pattern either. So then question came that whether it is going to be of any added benefit if we are going for chemoradiation compared to chemotherapy. And this study advocated for lower third adenocarcinoma chemotherapy compared to chemoradiation, chemotherapy was equally good. Second one came, although it was for stomach as well as GE junction, but this gave important idea about the lower third esophagus as well as GE junction tumor, because almost 1/3 of them, a significant number, almost 200 patients were included in this one. So perioperative chemo, both the FLOT as well as ECF were allowed in this one and compared with NSCRT. Again, there was no difference in overall survival or the progression-free survival. This study also suggested a kind of equipoise, that if it's a question about choosing the neoadjuvant treatment, both are equally good, or rather to reduce the morbidity, you can also go for only chemotherapy as far as adenocarcinoma is concerned. And recently appearing new Esophageal trial. Again, this was also either T2 or N plus tumor, 200 plus patients, compared again with FLOT versus 217 with the cross trial. And this is the one which is showing actually better 3-year OS for FLOT regimen compared to cross. Mind you, this was only for adenocarcinoma, not for anything else, and comparable toxicity. So from now onwards, more or less the balance is tilting towards neoadjuvant chemotherapy rather than chemo radiation for adenocarcinoma. Now, what about squamous cell carcinoma? Yes, traditionally it has been cross protocol, but just you should also remember a couple of things about the cross, that it was again a heavily dominated study by adenocarcinoma. Squamous cell carcinoma were not more than 1/3 or so. And even the middle third, which is the very much common variety in India, less than 20% of them were the middle third squamous cell carcinoma. So how much credence to give to that? I'm not trying to say that the protocols should change, but then these are certain riders one should be aware about. The biggest study regarding the squamous cell carcinoma came from Japan. That was the next study. And here, neoadjuvant chemotherapy, there were two protocols, CF and DCF, were compared with NSCRT. Fair amount of thought was given why these two were kept, because the CF was the traditional protocol there. And in the end, it turns out that 3-year OS is best for the DCF regime. But it is also true that the toxicity in the DCF group was, and the significant toxicity was highest. That was to the tune of 16% or so. But then it gives, for squamous cell carcinoma, DCF is a good option. And study went on to recommend that from now onward, the standard option for squamous cell carcinoma is neoadjuvant DCF rather than chemoradiation. Although that has to be taken on a broader scale, and slowly it will be coming actually on broader scale. But that's where we can go in terms of the evidence right now. And vast majority of the centers are still preferring cross protocol, but slowly this protocol is also going to pick up. Chemo versus chemo radiation, because that would have been a fair comparison, because three modality versus one modality is not exactly a fair comparison. And chemo versus chemo radiation, still there is not much of clear choice in terms of survival. So both the options are open, and you should have your choice based on the patient condition as well as preferences of the institution. Both the protocols are there, higher rate of PCR, but is that translating directly into survival compared that is still contentious, and both the choices should be kept in mind. Patient selection should be judicious based on the comorbidity, based on the nutritional condition, based on the general condition of the patient. What that is more important, and particularly it should be cautious in patients with poor nutritional status, also with those who have lost significant weight loss. There probably the balance will slightly tilt towards neoadjuvant chemotherapy, which is a equally good option, if not a bad option. Post-neoadjuvant assessment, again, PET-CT is preferred, but like Dr. Virendra said, that CCT is also acceptable. It's not mandatory. And when, as per the existence of the logistics, CCT can also be provided. The initial evaluation has been done with the PET-CT. We did our own study, and PET-CT was comparing with the pathological response, and there was very good comparison, direct correlation with the PET outcome with the mandated response after the neoadjuvant treatment. Now, next point in contention was post-neoadjuvant strategy. Should there be observation or surgery? So far, the existing on the traditional thinking is that, yes, irrespective of the response, the surgery should be offered, because there is no guarantee for 100% foolproof PCR rate or the PCR existence. Because the average PCR rate in most of the studies have been 25 to 30%. And since rest of all the patients are also being offered surgery, the question was that should it be routinely offered to all the patient, or there should be a choice for the patients to make, and on what basis they should make a choice. Informed choice should be both for the clinician as well as the patients. Can they be spared surgery? And that was the idea behind SANO trial. But you should also keep in mind that the rigorous protocol which was followed for the assessment of and the follow-up of the patient who were deemed PCR. Because every 3 months you have to go a combination of 3 investigations, that is PET-CT, upper GI biopsy, that is biopsy over biopsy, and endoscopic ultrasound with sampling, with or without sampling of the nodes whenever it is significant. Although this trial did say that, yes, this was a non-inferiority trial, and it did prove non-inferiority in surveillance versus surgery, but then it has to be taken with the context of the application in day-to-day practice. And post-operative complication, it also said that after postponed surgery, more or less, although they were similar, but then this is just one study, and that should be taken like that only. So it's not right now. If you are asked to make a choice or answer that in exam, the answer should be that I will go for surgery, although observation is an option, but then there are certain riders behind that. Now, if we come to surgery, what about the modality? Or where should the anastomosis? Because there are issues with the McKeown's esophagectomy. There are 2 issues. One is the leak rate and also the recurrent laryngeal nerve palsy, which are essentially much lower. The recurrent laryngeal nerve palsy is almost nil in Ivor-Lewis esophagectomy, unless you are going for supraazygous rigorous lymph nodal dissection. Leak rate, yes, it's lower, but then it sometimes can be very, very lethal. So there is a balance. There has to be a balance between. But for lower third esophagus, this is quite a valid option. But we don't have, although there are a couple of trials which are going, and one trial has already come in the randomized setting, head-to-head comparison. The important rider is that essentially there should be no evidence of nodal involvement in the supraazygous compartment, and it should be a lower third tumor. These are the ideal candidates for. So that boils down to essentially lower third adenocarcinomas, where these are patients where most of the time this thoracic anastomosis or Ivor-Lewis esophagectomy will be utilized. This was a comparison of in form of meta-analysis, and it says that the results revealed that minimally invasive McKeown's was superior to minimally invasive hyperleukemia in hospital cost, but inferior to in operating time, length hospital stay, in hospital mortality, 30-day mortality, and anastomotic leakage as well. So there is a place for both of them, and for lower third, both the choices are valid provided certain riders you remember. Another study, again, both are equally well. Also, we have our own experience, and that was again in terms of short-term complications. Now we have also analyzed about the long-term survival. More or less, both of them are safe, provided we are choosing our patients carefully. That is lower third esophagus and no evidence of nodal disease in the upper compartment. Then comes the surgical approach. That what should be the whether this is a transthoracic or transsciatal. That debate is more or less settled. That transthoracic approach is preferred. In the end, I'll also tell you about the non-transthoracic approaches, which is slowly coming up. Then comes the open versus minimal invasive approach, minimal access approach. There are definite short-term benefits of MIS, but whether it is equally good in terms of the long-term outcome and also the preservation of recurrent laryngeal nerve, lymph nodal lead, that part is slightly tilting the balance in the favor of minimally invasive approaches. The new debate is going towards the VATS, which is also minimally invasive, versus robotic assisted, that is both the minimally invasive. Open versus minimally invasive, more or less the debate is settled, both in terms of time trial and examining rightly answered and Miro trial as well. Recently, 5-year survival for Miro trial came, although Miro was a hybrid approach, and both were found to be not much of significant difference, although that was favoring more statistically, not to the extent of significant p-value, but it was favoring minimally invasive. So both that debate is more or less established, and in future you can expect that minimally invasive hysterectomy will slowly become standard of care. The long-term outcome of the robot trial which compared robotic hysterectomy versus open hysterectomy, and 5-year overall survival was equally good. No difference in DFS or recurrent pattern. So again, here compared to open hysterectomy, which is so far was considered to be gold standard, minimal access, both VATS as well as robotic, they are performing equally well. And this is a 5-year result, so long-term outcome is more or less established. There are 2 ongoing trials. One is the RAMI trial and other is the extended version of the previous robot trial, that is robot 2 trials. In future, they will be making the evidence for comparison of VATS versus robotic, because both these modalities are there, and one versus other superiority having been that at the particular debate, that is not going to matter much as far as compared to open versus minimally access. So more or less, the debate will be favoring the minimal access surgery, and that is they're going to be in future slowly, both in terms of lymph nodal yield, which is higher in RAMI, also higher chances of preservation. If you are going for a classical or complete two-field dissection, then preservation of recurrent laryngeal nerve is far better in robotic esophagectomy compared to VATS esophagectomy, but then has to be proven in a randomized fashion, and these 2 trials are going to answer to that. As far as blood loss and operative time is concerned, definitely blood loss is much less in the minimal access, more so in the robotic one. And operative time is slightly an issue, particularly in the robotic arm. The operative time has been shown to be on the higher side. Why I'm talking in detail about these issues? Simply because as future surgeons, you are expected to have skills which are up to date and we should not be lagging behind. And minimal access hysterectomy is something that is going to be standard, and definitely your skills should be upgraded to that level. Lymphadenectomy again has been contentious issue. You can see the picture of one side is infraesophagus. or the infracarinal lymphadenectomy, which is the standard. This is the supraazygous. Sorry, this is the supraazygous, the classical 2-field, and this is the classical 3-field lymphadenectomy. Lymphadenectomy remains an integral component of hysterectomy, and a minimum of 15 lymph nodes should be harvested. But more important than just number of 15 is that adequate number of fields have been dissected adequately. Because if you just take out from 15 nodes from one field, either abdomen, or you have done a very good dissection in abdomen and a very shoddy kind of dissection in the thorax, although number of nodes will be 15, but if that is a representative lymphadenectomy, that is questionable. So it's important that the number of fields which you have represented or in your operative notes should be classically adhered to that. For middle third tumor, yes, supraazygous dissection is more or less important and it should be done. The old debate of 3 versus 2 field, that is still not settled, and whether how much advantage is there for going for cervical field, I'll just briefly touch upon through the some of the studies. Just to give you a picture that once you have done a good lymph node dissection, the nerve should be clearly seen, which is the advantage of having a magnified vision, both in the both form of minimally invasive hysterectomy, more so in the robotic form. Here you can see clearly the left recurrent laryngeal chain of the lymph node which have been dissected. This is the lymph node chain, and this is the nerve which is after dissection, and this is the arch of aorta. So once you clear that, the structure should be seen clearly. Now, if you go to the randomized evidence of 3-field versus this, the recent one, and this was a RCT of 400 patients, middle and lower third esophagectomies. Primary endpoint was again overall survival, and the inference was that no improvement in overall survival or DFS after hysterectomy with 3-field lymphadenectomy. 3-field lymphadenectomy offered more accurate tumor staging with more than 20% of the rate of unforeseen cervical lymph node. I'm not trying to pass a judgment on, but on any of the lymphadenectomy modality, there are proponents for both of them. But then the literature more or less is very guarded about the remarkable advantage of 3-field lymphadenectomy. And the Tata study will be throwing much more, light on that in the long-term outcome of the 3-field evaluation. The current role is that the clear survival advantage is not proven and appears to be beneficial in upper and middle third tumors, but not in lower third. That the general statement you can safely say. The balance of the dissection and the morbidity, that is the most important criteria which policy you should go for, and that is again institutional variation subject to their experience in terms of their morbidity, but the target level of recurrent laryngeal parasites should never exceed beyond 10% or so. This I am talking about that even temporary and certainly not more than 5% of the permanent recurrent laryngeal parasite. If your experience is more than that, probably you should think about going for a 3-field lymph node dissection, and there should be change in policy for that. Now, what about the post hoc analysis in cross? What does that say? Because that's the most widely utilized protocol. It says that after neoadjuvant chemoradiation, number of resected lymph nodes was not associated with survival. These data question the indication for maximization of the lymphadenectomy after neoadjuvant chemoradiation. Indirectly, it's tried to say that neoadjuvant chemoradiation can take care of the nodal sterilization to the extent that extent of the nodal dissection or the aggressivity of the nodal dissection might not be a big factor as far as the survival is concerned. Now, bit about the adjuvant treatment. What about the adjuvant chemotherapy? Almost no role for patients who have got PCR, but then debate is still there for patients who have residual nodal disease and particularly with R0 resection, who have undergone R0 resection. Although there are some teams which are utilizing adjuvant chemotherapy, but there is an option and more being utilized for total neoadjuvant chemotherapy. That is the more or less standard of care. And at least in adequately dissected nodes where the surgery has been optimal and adequate, there is no role for adjuvant chemotherapy if patient has received, as per protocol, the neoadjuvant chemotherapy or chemoradiation. But yes, like it was pointed out, the checkmate trial and nivolumab for 1 year after arterial resection having residual tumor, that is so far the standard of care, and that is approved modality as well. Adjuvant pembrolizumab, now it is being tested, but so far the randomized data to the large extent just utilizes a number, some of the studies which are less than 100 or rather less than 50. So large scale data is still to be seen for the pembrolizumab, but you will see and you will hear about much more in the future studies because a number of them are undergoing right now, and in next 2 years you will be getting much more information about the role of the exact role of immunotherapy, both in neoadjuvant setting, also in the adjuvant, more so in the adjuvant setting. Now, bit about the old giant or the old debate, that is, what about the definitive CT-RT in resectable tumors? That debate has started in last 3-4 years to the extent that some of the trials were being planned for definitive CT-RT in resectable tumor. But so far the standard is that till the time we have much more literature or robust literature in that, the standard answer is still that after neoadjuvant chemoradiation or definitive chemoradiation, rather definitive CRT, if there is a good response, that should be taken off only for salvage hysterectomy. After neoadjuvant complete response clinically, all patients should be offered surgery. Why is that? Because so far the role of definitive chemoradiation has been described only in the older randomization data before at least 10 years or 15 years. And meta-analysis, which was, although robust one, I have given the snapshot of that, almost 30,000 patients. That was also showing better overall survival for the strategy of neoadjuvant chemotherapy, chemoradiotherapy plus surgery versus definitive CT-RT. Although this study and the meta-analysis had a mix of the patients who were both resectable as well as locally advanced, but then in general, for your answer, locally advanced, when it is going for definitive chemoradiation, the role of surgery in the salvage setting. Otherwise, for all the patient, neoadjuvant treatment followed by surgery is the standard of the treatment. Important is that now when the data comes for resectable tumor and we are offering for definitive chemoradiation, again, there will be a question of how do we predict or how do we establish the complete response? That is a contentious issue, and that answer is still there. Little bit about transhiatal in a different form. Essentially, what it is, that combination of the minimal access transcervical and transhiatal approach. Transhiatal is again either through VATS or robotic, which the visual access can give you access right up to the clearance of the nodal basin in the subcarinal region, and remaining can be done through the transcervical approach. Why this came into fashion is that because morbidity of the thoracic approach, the most common complication is still the pulmonary one, and it happens. This approach is assuming essentially to prove that the incidence of pulmonary complication after esophagectomy can be lowered down if we avoid the transthoracic approach. So this is one methodology coming up from Japan, and large scale data is still not much there. The last study had only 22 patients, but then you should be looking up to that in future. Avoiding transthoracic route has been contentious, but then so far that is the standard approach, and the pulmonary complication, the approach related pulmonary complication is expected to go down. This is the basic premise of the non-transthoracic approach, that is combining VATS with transcervical. And in this particular study, it was shown that robotic-assisted transarterial mobilization was of greater help, at least for the nodal dissection, because there was no compromise on the extent of the nodal dissection in this study also. And so far, it is stressing more on the robotic mobilization of the transarterial route. So I will finish here just to give you the snapshot of whatever I was talking about. It's important to understand that disease biology of adenocarcinoma and squamous cell carcinoma are totally divergent and different. And that is now being translated into multimodality approaches for these two, although both of them will require, but then value of radiation in adenocarcinoma is slowly going down, and neoadjuvant chemotherapy is now taking over. And there will be no surprise that sooner or later it will become standard of care. Neoadjuvant chemotherapy, neoadjuvant treatment, sorry, not chemotherapy, is required for all patients except T1N0. But then how do you choose your strategy? That is dependent on the patient condition. Both the options are, the valid options are there, and the choice has to be made according to the condition and the tolerance of the patient. Observation is an option after neoadjuvant treatment, but rigorous patient selection method is required, and essentially and not probably still surgery after neoadjuvant treatment is the standard of care. Minimally invasive esophagectomy is slowly becoming standard of treatment. VATS versus RAMI trials are going on, and that debate will be settled in future. Lymphadenectomy is, as far as extent is concerned, it's always important that a thorough lymphadenectomy is offered, and that is minimum of 2-field lymphadenectomy is required, and that addresses the representative 3 fields. I'm not saying the cervical field, but rather supraazygous, infraazygous, and abdominal field. So minimum 2 field, that is abdominal and thoracic comprehensive lymphadenectomy should be recommended. Immunotherapy will be slowly picking up both in neoadjuvant as well as in adjuvant setting, and it will have an increasing role in future. I was allotted that much of time, so I apologize that I cannot go into much more depth of the newer advances. That would have been better, but then for today, this much. Thank you so much for your patient timing. I'll be open to answer certain questions if they are there through my email I have given here. Thank you very much.
Thank you, Sunil sir. As usual, a very balanced talk covering most of the aspects of esophageal cancer management. I invite Dr. Virendra Tiwari back for the final aspect of this, which is Q&A with our experts. I'll start with the first question. So these questions are essentially some taken from the Q&A here, some from the YouTube, and the matters for which level A evidence is not there yet, but we want to know what the experts' position is on these matters, is what we want to look at. So I'll start with Dr. Virendra. Esophageal squamous cell carcinoma with a pulmonary or a bronchial fistula, how do you manage them? And I think this question was put from the point of view that obviously surgery is not indicated for these, but a lot of times radiation is also not indicated. So do these patients undergo only palliative systemic therapy or how?
So as there is a fistula, we need to take care of that also. And obviously not resectable. And as you said, definitive RT is also not possible in such scenarios. Then to start with palliative systemic therapy, and if affordable, add immunotherapy also. And obviously get an opinion for a gastroenterologist whether endoscopic stenting is possible, which will cover your fistula as well as take care of dysphagia. So palliative, yeah, but.
Sunil sir, anything from your end?
Agreed. I think more or less agree with what Dr. Virendra said. And this is kind of a tricky situation, to be honest. And whether by that's what most of the time we land up with that pulmonary fistula. Before you start any sort of treatment, our radiation oncology or rather chemotherapy, they will ask for stenting to be covered not only on one side, but both the sides. And that's what we are practicing commonly as well.
For the second question, I'll post it to you. For seemingly early tumors, which are eccentric, not concentric, small growths, no nodes, can we offer upfront surgery?
Yes, you can. The short answer is yes, you can, provided there has been good assessment and reliable assessment that it's just not the morphology of the tumor, but the important is that depth should be assessed. And here, probably the role of endoscopic ultrasound becomes more important. If you have a doubt, it's better to err on the higher side. That is, go for neoadjuvant treatment. But if the patient condition and suppose 75 plus, if you are talking about that, I will not be going for a neoadjuvant treatment in that scenario. Eccentric, small growth, no nodes, yes. Definitely there is a role for upfront surgery. And like Dr. Virender said, and I agree with that, even T2N0, they will qualify for that. Although most of the trials, they have included T2 in their domain of neoadjuvant treatment, but T2N0 definitely can qualify for upfront surgery.
Right. So I think Dr. Virender, you can give your opinion on this question and take the next one as well. For patients who have undergoing or undergone EMR or ESD, how do you decide additional treatment at your MTPs?
So I absolutely agree with Dr. Sunil. So it has to be staged properly. We need to get a EUS done. For the second question I'm talking about, we need to get a EUS done. We need to be very sure that it is T1, T2. Then only there is a role. Or if there is any contraindication to systemic therapy, then in these two scenarios, you can, plan for a upfront surgery. Coming to third question, EMR, ESD. So everything depends upon what is the endoscopic picture. And what was the objective of doing EMR EST? If it was only for a biopsy, then it is an inadequate treatment. But if it was a smaller lesion, 2 centimeter or less, not a poorly differentiated variety, and we have done ESD, that is endoscopic submucosal dissection, not EMR, for a curative intent, then the pathology will decide whether patient will need adjuvant any further treatment or not. T1A margin negative, it's okay. Even T1B SM1, it's acceptable, but again, nodal spread is slightly higher. So T1B or anything more than that will need adjuvant treatment, or if there is a lymphovascular invasion, or if your margin is positive, in such cases, patient will need additional treatment like surgery or RT.
Right, sir. Sunil, sir, anything on the third question? Additional treatment after EMR ESD?
No, it's important that you get the biopsy correctly. If there is any doubt, then yes, it's better to, if it's a question of observation versus surgery, then you should err on the higher. If your gastroenterologist, if you have a very reliable equation and the histopathology is reliable, then yes, you can certainly observe for that, provided there has been a rigorous nodal assessment, because here comes the role of the good nodal assessment. Not only the T stage, but N stage is equally important, because anything which is T1B or so, yes, chances of lymph nodal involvement will be there, and that should be kept in mind.
Right, sir. For the next question, for patients with supraclavicular lymph node positive disease, how do you manage them? Sunil, sir.
Are you expecting that? And let's take in a practical way in two contexts. One is someone who has got middle third or upper third tumor with isolated supraclavicular lymph node, maybe single or so. Other extreme is that lower third tumor, multiple nodes, also supraclavicular lymph nodes. Probably choices are very clear in these two. That if it's a isolated single supraclavicular lymph nodes in the absence of other sites of lymph node, the involvement, probably the approach will be curative. And by that, all the, armamentarium of the treatment will be utilized with the rider that yes, chances of post-operative complications are higher in such scenario, because you are going to irradiate partly the neck area also. But then whether to utilize radiation in such a scenario, that is another question. And personally, I will prefer not to do that. It's better to go for neoadjuvant chemotherapy approach, see the response. If there is no response, then you can safely convert that into definitive chemoradiation. If there is a good response, if there is a residual disease, which is either doubtful, fibrotic, or isolated, yes, surgical resection may be offered in that. But there is no sacrosanct basis. Theoretically speaking, yes, the entire supraclavicular right up to celiac is in the domain of the nodal dissection. That is true. But then is that biology really favorable in terms of translation into the survival? That is a big question. And that is where probably the aggressive surgery most of the time will fail, because most of these patients will have N2 disease, and the value of the even aggressive surgical resection is not proven in that scenario. So multiple sites, multiple nodes, answer is no. Isolated site, single lymph node, answer will be yes. Lower third, supraclavicular, probably the answer will be no again.
Right. So I think Dr. Virendra, I'll pose the same question to you in a different way. So if you have, let's say, a single supraclavian lymph node positive, till what position of the esophageal or G-junction tumor does it remain regional lymph node for you?
So, histology also decides. Adenocarcinoma, lower third with supraclavicular node, that becomes metastatic. And if you see ninth edition, I think Japanese classification or ninth edition, again, lower third esophagus with supraclavicular node, they are calling M1.
M1, yes.
Yeah, so it becomes metastatic, but till now, what Dr. Sunil said, squamous cell carcinoma, not adenocarcinoma, squamous cell carcinoma, yeah, with no significant nodal burden, with few upper mediastinal with supraclavicular, we still, can consider for downstaging followed by three-field nodal dissection, provided patient can withstand that surgery.
Perfect. I think the last question for both our experts is their indications of DCF today, and what sort of adjuvant therapy is offered to these patients after surgery based on the final histopathology. Sunil sir and Dr. Virendra.
Maybe Dr. Virendra will like to take up first.
No, sure. Sir, go ahead.
Okay. So what we have started is not the exact DCF. What we have started is the modified DCF regimen, where the dose of docetaxel is slightly lower compared to what was given in the Japanese study. Number one. Number two is the frequency. That is, we are giving at 2-weekly interval. This is more of not a routine for all the patients, but then primary criteria is that general conditions should be good, preferably ECOG 1, not 2. For remaining patients, yes, paclitaxel, carboplatin is the choice, but DCF is number one for good general condition, relatively younger, and slightly in the dose modification form, because we have just started for last 1 year.
And sir, is it for all comers of squamous, or how do you choose your indications for DCF versus cross?
Now, regarding the cross versus DCF, we had a kind of a non-conventional or non-traditional reason in the form of logistics. The management and the coordination of the chemoradiation is a big challenge, and particularly in a government hospital, it's not an easy job. So most of the time, we go for that. But the problem is that we had to keep one avenue open for the patients or to overcome this logistic challenge also. And that's where the data was essentially kind of a blessing in disguise. We had our own trial of pre-op chemotherapy versus pre-op chemotherapy, which was tested in two forms, that is cisplatin 5-FU in the classical form, that is 5-day infusion, and paclitaxel carboplatin. So that was the first part of the trial, that, okay, if we go for neoadjuvant chemotherapy, how are the results? And we compared that with our ongoing neoadjuvant chemotherapy, not in randomized fashion, and both of them were fairly comparable. Both the regimens also fairly comparable. and that's where we got the idea that probably neoadjuvant chemotherapy is an armamentarium which cannot be just pushed aside in the favor of cross, and that should be pursued. And also, when the DCF data came, then we were slightly apprehensive in terms of the tolerance of the regimen. Even in the Japanese population, it was as high as significant morbidity was 16-17%. So we were slightly guarded about that, and in good general condition patients, we wanted to try slightly dose modification was done. As far as adjuvant is concerned, after DCF or after complete neoadjuvant chemo radiation, we are not going for any adjuvant unless this is a N2 disease. More so, patients who have received only neoadjuvant chemotherapy, those who are N2, they will be given adjuvant chemo radiation, remaining all, including N1, no adjuvant treatment.
Dr. Virendra, your answer for the same.
So I think Sunil sir has already summarized. DCF is a very toxic treatment, and if you see that Japanese paper next trial, even they have said that neutropenia, I'm not very sure, but it is somewhere close to 50-60% in a patient receiving DCF. It needs admission. So in their conclusion also, they have said that if you think that patient cannot tolerate DCF and you want to give 3 drugs, even FLOT can be attempted, because you have removed the cisplatin component and added oxaliplatin. So, and another thing is that when you compare to neoadjuvant chemo radiation, even in that trial, there is no comparison between neoadjuvant chemo, I think, with DCF versus this. So neoadjuvant chemo radiation has become a standard, and it is very well tolerated. And squamous cell carcinoma is a histology where you need a better local therapy. So adding neoadjuvant chemo radiation and then operating is not a bad option still, I think. But only thing is that if you see cross, I don't think we see a kind of disease that cross had included. We see patients with extended cross. Their tumor size was 4 centimeter, ours is somewhere close to 8 or 10 centimeter. So, you have to decide on patient to patient basis. But neoadjuvant chemoradiation for a middle to lower third squamous cell carcinoma with no significant supracarinal or abdominal adenopathy, I'll still consider that as an acceptable option. But if patient is very fit, then in such scenarios, you can try DCF also.
So I think if we can take away from the experts regarding this question for the students, it would be that cross, when possible and within the criteria of the cross criterias, that remains the standard of care. And only if the tumor and the nodes are outside these fields, that the cross field cannot cover it, only then in a very fit patient, probably DCF can be considered, or for logistic reasons, as and when there are in institutes. I think both examiners would agree with that statement.
Just one comment. We had published one paper where I was working in a center where there was no radiotherapy. So we did a head-to-head trial of 65 cases of squamous cell carcinoma esophagus, and with cross protocol versus only the chemo part of the cross protocol. It is not DCF. So there also what we found is all the patients did quite well. So the inference is it's tilting towards neoadjuvant chemotherapy, then chemoradiotherapy.
All right, sir. So I think with that, I would like to thank both examiners, Dr. Sunil Kumar and Dr. Virendra Tiwari from my side, for being so patient during the Q&A and throughout the excellent webinar conducted. I invite IASO Secretary Dr. Rudracharya to kindly deliver his remarks and deliver the vote of thanks.
So that was a wonderful program with both the candidates did very well, and Virender actually he almost took the whole thing, the practical aspects very well, and Dr. Sunil as usual is always classical in his practical to the point in his talks. So I think it was a great class, and I had a specific interest in esophagus. So since morning, I was thinking how it will go, we will see, and it went very well. So I thank all, and I thank Indo-American team for bringing up this with the this masterclass. Thank you very much.
With that, we would like to conclude the webinar for tonight. We thank you all for joining in. Our next webinar from IASO Academics would be on 29th of July, and it will be on esophageal cancer. Today we discussed the theory. We'll then discuss the art of surgery, which would be covered in the IASO Mastery of Surgery on esophageal cancer surgery on 29th of July, 7 p.m. Kindly join us for the same.
And all of you, the abstracts for the NatCon IASO Goa is open. All of you students can put your abstracts and present your work in a big way at NatCon Goa. All of you are welcome.
And register for the conference.
Yeah, definitely. Without that, it's not allowed to put the abstracts. Yeah.
All right. Thank you and good evening, everyone.
Thank you very much. Thank you.
Yeah, thank you.